Well, hello everybody. Thank you for joining us today for this presentation on the new role of therapy under PDGM. I know quite a few have been asking questions about the slide presentation. It was my fault. I guess I'm emailing or texting someone right now to load those slides for me. I didn't realize I was supposed to do that, so sorry about that. But they should be made available here like really soon. So just double check as we're going through this presentation. Well, like I said, thank you everyone for joining us today. This is the first part in a three-part series that we're going to discuss specifically therapy. I know I get a lot of questions about, okay, what's therapy going to look like come January 1? So how are we going to have to change our practices or how are we going to have to recreate ourselves? So that's what this three-part series is going to be on, is to sort of kind of give us an introduction, an idea of what we think. Now, y'all, nobody really completely knows how this is going to impact all of us financially. All we can do is predict, kind of run models to see which one would look the best or not. But the one thing that I typically tell agencies is that, don't focus totally and completely on the bottom line. I know the bottom line is extremely important, but if you are giving care and you're giving it at the amount in which the patient is showing positive outcomes, and you're constantly reevaluating those outcomes to make sure that you're achieving your set goals, there's going to be a balance there. It always, typically, in my experience, is. So with that said, let's go ahead and get started with the highlights of this. So of course, I told you that it's one part in a three-part series of fine-tuning your therapy documentation, which will be the next one, which we're going to focus a good bit on documentation standards. The last one is going to be specifically talking about therapy utilization and thinking outside the box and how to recreate ourselves as therapists. And this would be PTOT and ST. So please note one thing, we are skipping the week of Thanksgiving next week. So otherwise we would have the three-part series, every single week, this week, next week, and the week after, but we're skipping next week. So remember that. And of course, if you attended today, of course, you're going to get the information, but it will be made available also on our solution shop and the guide to therapy documentation. Okay. So let's go ahead and get started. I'm not a big reader of stuff. Now, there's certain things on this presentation that I'm going to read because it's straight from Medicare, and I want to make sure that you get the understanding of it. But here's the objectives. I'm not going to go over that because we've got a lot of material to cover. So let's review. Now, don't get mad at me. Oh, Lord, homebound status. How long have we had homebound status in Medicare? Well, you say that, and then I sit there and I read a chart and I'm going, did you tell me criteria 1 and 2? Okay, you told me one piece, but you didn't tell me the other one. So we're going to kind of review that because you can't really do this without reviewing those parts, because we're not only talking about therapy under PDGM, we're also talking about how to document in order to prevent denial, because a lot of home health agencies have either already been through all of these ADRs or they're currently going through different rounds of ADRs, Z-PICs, U-PICs, whatever you want to call them. People that are trying to take your money back. So let's talk about what Medicare says. So the patient eligibility, of course, you've got to be confined to the home, and you've got to meet at least one of the first criteria in that first column, and you also have to meet both of the second one. So there again, remember that they've got to have an illness or an injury that they require some sort of assistance of a supported device and or the assistance of another person in order to safely leave their residence. Okay, they've also have to have a condition that's such that leaving his or her home would be medically contraindicated. Now, number 2 would be more like this patient is immunocompromised. This patient has a psychiatric issue that would prevent them from leaving the home. So those would be examples of part 2. The second criteria, of course, you've got to meet both of these, and there would be a normal inability to leave. There must exist a normal inability to leave home, and also leaving home requires considerable and taxing effort. Now, you can't just put that verbiage down. You have to tell me why they meet criteria 1 and why they meet criteria 2 in both sets. Okay, so that's just sort of a review of that particular section of the Medicare manual. So understanding versus documenting. Okay, let that sink in a little bit. I have a lot of people that understand what it means, but to document it on a sheet of paper is another thing. Okay, so a lot of times people, nurses, therapists, you name it, we all think that we're conveying what we did for this patient and how we did it and why they needed the services in our head, but getting it from the head to the paper is two completely different things. So let's go over things that you need to consider, specifically regarding homebound status. So you need to think about the terrain that this patient is navigating to exit their home. Okay, steps, the number of steps that they have to get to the garage or get out the door to get to their car. We need to be very specific about these things. Any handrails that are on those stairs, any gravel or tree roots. Now, y'all, I live in Alabama, and every front yard in Alabama has some pecan tree or some hardwood where the roots are actually above ground. So, tripping hazards are, we have a lot of broken hips here in Alabama just by being out in the yard picking pecans. So, be mindful of the terrain. Describe it in your documentation of why it's unsafe for them to get to the mailbox, because they have to go over different surfaces in order to get there. They've got to go down 5 steps. They've got to cross over, a cracked sidewalk, and then they've got to go to the graveled area to get to the mailbox. And getting to the mailbox is really important. Okay, so what must this person navigate in order to get from their apartment in an assisted living to the dining hall? Okay, some of these assisted living facilities have multi-levels, but the dining hall is in a common area on each of the floors, or maybe they've got to go all the way down to the bottom floor in order to get their meals. So we've got to document the reason why it's going to take this particular patient 300 to 400 feet in order to get to their place to eat, compared to someone else who only has to walk 50 to 75 feet. So we've got to tell the auditor, we've got to tell the person that's writing or that's reading your documentation that, look, they have to get out of their apartment. They have to walk 100 feet down the hall. They have to get into the elevator. They have to take it down 4 floors. Then they have to walk out of that elevator, go around the corner, down the hall, another 200 feet in order to get to the dining hall just to eat. And then they got to repeat that to get back up. Okay? So we have to be very specific about those things. The amount of time it takes to recover. Does the patient have to navigate a crosswalk to get to public transportation? Okay, so a lot of areas, not necessarily here in Alabama, but a lot of the areas use public transportation. So how long would it take for that person to get across that crosswalk? So think of different tools and things that you can use to help describe, this patient's deficit in doing these things that would make them homebound. So let's talk about the assessment requirements, the evaluation, the reevaluation, and what Medicare wants. Okay, so the assessment requirements, you must assess the patient using a method which allows objective measurements of their function and successive comparisons of measurements. Okay, so you've got to use certain tools and that are in your toolbox, and all of you therapists, PTs, OTs, and STs. STs have, oh my gosh, a ton of different tools in their toolbox in order to assess objectively what's going on with this particular patient and what their functional deficits are. Objective measures, you've got to tell me about their activities of daily living, specifically for your OTs and your PTs. You've got to tell me, eating, swallowing, bathing, dressing, toileting. I mean, this is y'all's wheelhouse. This is where y'all live and breathe, okay? Cognitive factors that can affect this patient's ability to perform their activities of daily living safely. And of course, additionally, at the time of reassessment, at least every 30 days, but it can be more often than that, the therapist is to, quote, and I took it straight out of the Medicare manual, compare the resultant measures to prior assessment measurements. So whatever tools that you used at the time of initial evaluation, when you go to reevaluate that patient every time, you need to use the same tools. Okay, so let's talk a little bit about that. Objective measures. Okay, now I know that y'all are going to scream at me over this webinar. I hear you screaming. I feel your pain. Okay, but what we have to do is abide by what Medicare wants us to do in order to get paid for the services, for the valuable service that we provide the patients in their home or wherever it is that they live. Okay, so a lot of different tools that we have at our disposal depending on what we're trying to measure. The Tinetti score. Most of our physical therapists use the Tinetti. It's easy to use. It doesn't take very long to administer. It measures different, your balance and your gait, those kinds of things. The Berg. Typically, the Tinetti and the Berg are typically interchangeable, but most of the physical therapists specifically like the Tinetti because I'm thinking that it's easier to administer. It's got less questions, okay? The functional reach, that can be a physical or an occupational therapist. Functional reach is very important in assessing falls and assessing the patient's deficits in order to tell me why it is that this person needs these particular exercises to improve their reach. The mini mental status, that's going to be a lot in your speech and your occupational therapist, specifically occupational therapists when they're trying to do cognitive re-education or compensatory strategies when dealing with patients who have cognitive deficits. Gait velocity. So when would that be appropriate? Think about that patient in some of the areas that you service where they have to take public transportation. So if it takes them an extended length of time to get across the crosswalk, and that's one of their goals, and it's achievable goal, then we may want to use the gait velocity in order to document those improvements in tying it to that patient's functional ability to get across the crosswalk safely without getting run over by a car. The Barthel Index, that's very appropriate for your occupational therapist, your CATS ADL, your RIPA, and your Borg. If the RIPA G is specifically for speech therapists, I have to throw my speech therapist love. I absolutely love speech therapists. Not that I don't like PTs and OTs, but speech therapists do such unique, strange, weird things, and I just love to watch their sessions. Now, this is when you're going to start hollering at me, and it's okay. I've been hollered at before. I've been called names. It's okay. Don't use the tug, okay? The timed up and go. Y'all, I'm an RN. I can use a tug, but I can't use a Tinetti, okay? I will straight up tell you. A tug is a very simple assessment for falls, for fall risk, okay? Your Tinetti, your Berg, your functional reach, those are more tied into your interventions and your goal achievement. Do not use a tug, okay? It is not appropriate for my therapist. Now, this is where, like I said, I'm probably going to get hollered at. Your manual muscle testing and range of motion. Medicare considers these things more as part of your standard assessment than it does objective measures. Now, do I agree with this? No, I do not. Have I taken ADRs where the Medicare has said the therapist did not use objective measures in order to quantify their improvement, okay, or to incorporate it into their plan of care? I have argued it to Medicare, and they have come back repeatedly to say that just performing manual muscle testing and range of motion is not enough, that I have got to have some other standardized tool in order to measure improvement. Okay, so I'm on your side, but I also have to take these notes that the therapists write and try to plead my case to Medicare in order to pay for your 20 therapy visits or your 18 therapy visits. Okay. So let's go on, goals and standardized tools. So any tool that is used at the time of the evaluation, you'll need to incorporate that into your goals. So an example of that would be your patient's Tinetti score. It will increase from 16 out of 28 to 20 out of 28 by 4 weeks. That's measurable. That's tangible. I can touch it. I can taste it. I can smell it. Okay. So try to incorporate any tool that you're using into your goals. Okay. So all evaluations, now y'all, this came out of the Medicare manual. I didn't make this crap up. Okay. I'm not that creative. So all evaluations must contain these particular parts, okay? You've got to have the reason for the referral. Why is it that the patient needs the therapist? They fell and they broke their hip. They had an extended stay in the hospital, which caused them to have increased weakness, and or they had a stroke. I need to have the reason. I need the diagnosis. Is the diagnosis that important? Not as important as the reason for the referral. Okay. The past level of function. You need to be a little bit more specific. Patient was independent, prior level of function. Now you need to tell me different people have different levels of independence. Okay. I have a mother-in-law. She is 80 something years old. She's independent inside her home for the most part. You get her outside that home, girl is not independent. Okay. So you've got to tell me, independent is a very broad word. So you've got to be a little bit more specific to tell me that the patient was independent in their home, but they still needed assistance to get out of their home and into the car. Or they were driving and they were using no assistive devices and were independent at home getting their groceries and things before whatever episode of illness that they had that brought them to you. Evaluations must contain both physical and cognitive baseline data that's necessary for assessing rehab potential and also measuring your progress. So you've got to tell me cognitively, is this patient able to follow, multi-step types of commands, or are they simple commands? Okay, so patients that you're only able to follow simple instructions rather than more complex multi-step instructions, you need to make note of that, because obviously those patients are going to need more written material. They're going to need more caregiver assistance for reinforcement, and they're also going to need more time in order to achieve their goals. Okay, you've got to state that. Don't just assume that you wrote that they're oriented ×2, that I'm just automatically going to know as an auditor that, hey, look, this patient, it only took 2 weeks to achieve their goals. This one, it took them 4 weeks. Well, what's the difference? You've got to spell it out like I'm a dummy. Okay. Current level of function, which we've already gone over that. What is their current level of function? And compare that to their past level of function or their prior level of function. Use your objective measures, use your strength testing, use your range of motion, assessing pain. Y'all, you really need to assess pain before your assessment, before you start your evaluation, and then after your evaluation. Activities of daily living, and also any note of edema. Treatment techniques and modalities. So are you going to be using any E-stim? Are you going to be using any ultrasound therapy? And why are you going to use that? Selected for treatment for their current illness, their injury, which may influence their length of their treatments, because some of these treatments like E-stim for speech therapy and stuff, or vital stim, that takes a little bit longer. I expect speech therapists to be in the home longer because it takes them longer to achieve their goals just by the nature of what they do. Okay, so if you got a stroke patient that you're trying to teach safe swallowing, or trying to teach them, through their stuttering problem or any dysarthria or anything like that, where they're having expressive or receptive aphasia, that's very aggravating. It's very, it can be very depressing. So those patients are going to take more time than your simple patient who maybe has some generalized weakness or has some osteoarthritis, or maybe has a little bit of a stroke where they have weakness on one side. Short and long-term goals, okay, stated in the objective measurable terms with an expected date of accomplishment. Okay, now one thing I'm going to tell you about short and long-term goals, okay, y'all create them at the time of admission. But then when you go to reevaluate them, I find it hard to believe that the ones that you wrote 30 days ago are still appropriate 30 days later, okay, without any fine tuning at all. Because I know that I write goals for nursing all the time, and I'm constantly changing those goals, because I either overshot it or I undershot it. So you need to really look at those goals. The more that Medicare sees you changing that patient's goal from eval to re-eval, the more apt they are to say, okay, well, this patient really does need this much therapy or whatever it is that you're providing them. Frequency and duration, we're going to talk a little bit about that, but that's going to be on a future session that we're going to have. Rehab potential, of course, discharge plan. So the plan of care in Medicare. So now we're going to go into the interventions, okay? So we're going to go over interventions that would be good and goals that would be good and goals that would be a little bit better, okay? So the patient-centered approach, okay? So interventions need to be focused more on the patient than they do the exercise. And what I mean, when I go to read therapy notes, I see, that the therapist provided 10 squats times 2 sets, but you didn't tell me why that patient needed that particular exercise. Okay, you just fill in the exercise. Patient provided or educated or on blank, okay, in order to fix this functional deficit, in order to address and correct the functional deficit or to compensate for the deficit that they have. You need to focus more on what the patient's functional deficits are than the exercises that you perform. Okay, so tell me why you chose that particular exercise. Okay, out of all the exercise programs that you would pick out specifically for PT and OT, why did you choose this set of exercises? What is this fixing? Remember, treat me like I'm a dummy. Spell it out for me on your notes. Any challenges that the patient has in navigating their environment, any carrying load. So if you have got a patient who wants to be able to go back out doing shopping, going down to the corner market, they have to cross the street or they have to take public transportation to go get, so they're getting light packages or they're carrying one little bag or something like that, or even rolling a bag. We've got to challenge them with carrying those loads so that they'll be able to return to their prior level of function, and tell me exercises that you're going to do with this particular patient in order for them to be able to safely carry that load. Balance requirements for performing tasks, and that's a no-brainer. Directional changes. Any challenges, challenge the patient instead of accommodate. I see a lot of times where, and this is where I'm talking about challenge instead of accommodate. So, you've got a patient, they live by themselves. They're going to continue to live by themselves. So we're left with what we've got. Okay. We've got to try our best to make this person safe inside and outside of their home. And we identify based on your skill and your critical thinking that yes, they're going to be able to return to their prior level of function. And this is what I'm going to do in order to meet those goals. This is how I'm going to help the patient in meeting those goals. So why would you put the dog up? Okay, because I see a lot of times, I'm in the home when therapists do I still do visits in the home. So I see the therapist when they're like, okay, will you put, your little dog up so that we can make sure and do our treatment without any interruptions. Y'all, that dog's going to come back out again. And it's going to be up underneath Meemaw's legs, okay, or Meemaw's feet, or the cat, or the trash on the floor, because this is just the way they live. So we've got to educate and train these people to live in their environment. Okay, now there's certain things that we can change about their environment, removing throw rugs and things like that. But I've had some patients and families that were like, no, you're not going to touch my throw rugs. Okay, that's, those plastic tracks are there to prevent Meemaw's carpet from getting messed up. And I'm not going to remove them, even though they're dry rotted and they're curled up on the edges. So I've got to be able to teach this patient and this family how to navigate the current environment that the patient's in. So you don't need any specialized equipment, of course. You got your 2 hands, you've got a balloon, you've got, a little, I've seen occupational therapists do some really creative things with just a balloon, blowing up a balloon. So just using the patient's environment, incorporating your interventions into that plan of care. Okay, so go into this patient has a dog, this patient has a cat, and they're constantly with them. And the reason why they fell in the home and ended up fracturing their skull is because Cujo got out of the back room and ran up under Meemaw's legs and caused her to fall and crack her skull open. Okay, so we need to be able for Meemaw to navigate around Cujo. Okay, or to get the phone. A lot of people still have landlines. I know here in Alabama, a lot of people still have landlines. So we've got to be able to, for them to be able to get to that phone when it rings. All right, so see how they navigate. Call them on the telephone and watch them navigate to their telephone, because that's something that they're commonly going to do. So these are just ideas, okay? Just think outside of the box a little bit when it comes to this kind of stuff. So let's do the top denial reasons in Medicare, and most all of them center around goals. Okay, so these are the top reasons. So what I did is I took the Medicare administrative contractors, the big ones, Palmetto, CGS, and NGS, went on their websites, and I pulled up the top therapy-specific reasons for a denial of claims. Okay, so I picked out these 4 because they were the top ones. Okay, documentation submitted does not include measurable physical therapy treatment goals. Documentation submitted does not support the physical therapy services for reasonable and necessary. Documentation submitted does not include specific therapy goals. All right, so you out of the top 3, you've got two regarding goals that suck, okay, in your evaluation and your reevaluation, and also reasonable and necessary. Okay, so we're going to talk about those 2 things in the next few slides. So the first one is reasonable and necessary. Y'all, this is an extremely gray area. It's difficult to define, and even I have difficulty because I have to ask lots of questions to my clinician in order to determine whether what they're providing this particular patient or what they're planning on providing is reasonable and necessary. And it's largely dependent upon the patient's circumstances. So say for instance, and I use this a lot of times in a lot of my different classes. So you have 2 patients. One of them lives in a very affluent area of town. They have, they have COPD, for instance. Okay, they're on oxygen. They have 24-hour sitters. They don't ever miss their medications. They get good balanced meals 3 times a day. Their needs are met. Okay, they just came out of the hospital with an exacerbation of COPD. Okay, you've got this other patient. She lives in a single wide trailer back behind her daughter's house. Okay, she's doing the best that she can. Her daughter works 50 hours a week, as most of us do, plus. Okay, she's trying to take care of mom. Now, mom's home history and physical looks just like the affluent lady's history and physical. If you didn't see them, they would look exactly alike side by side. But the lady in the single wide trailer is living on a fixed income. She can't afford half of her medicines because COPD is a very expensive disease. Okay, most of the drugs for COPD cost a lot of money. So she has to decide between foods and inhaler. Okay, she's oxygen dependent. The daughter comes and provides her breakfast, but then she turns around and has to warm up something or eat a sandwich or something that's frozen that she has to thaw out. It's got salt in it and those kinds of things. Now, both of those patients had an exacerbation in their COPD, but due to their unique living circumstances, who do you think you're going to see more often? Who is going to require more of your services, nursing and therapy? Well, of course, it's going to be the lady in the single wide trailer back behind her daughter because she doesn't have the resources. She runs the higher risk of rehospitalization than this lady who's getting 24-hour sitter services with unlimited resources. They both need to be admitted. But this patient over here may only need a few visits compared to the single wide trailer that's probably going to need an entire CERT period of visits to keep her out of the hospital. The only way you can paint the picture of reasonable and necessary is to write their circumstances, right? Where they live, how they live, who they have available to them, what their financial resources are. You can't not write those things. Otherwise, you have not established reasonable and necessary care. Okay? They're going to deny your services, and that's exactly what Medicare is saying that they're denying for. You did not paint the picture. Okay? So, medical needs and circumstances. These are the things that we were talking about. Do they live alone? Do they live with somebody? Is that somebody available to them all the time, or are they just available to them at night? Do they have, or are they alcoholic? Okay, is the caregiver alcoholic? Are they drug users? Are they, is it the grandmother that is my patient, and the grandson lives in the back room and could be a serial killer, and all he does is provide grandmama with transportation because he's living off of grandmama's Social Security check. Y'all, I see those patients. Any history, any environmental issues that are going on with the patient, any social or psychiatric issues. Y'all, I can't tell you how many people I went into their house and they are straight up hoarders, straight off of the hoarders television show. I was like, I've been in that house. Okay. Recent falls. The increase in falls increases their likelihood for more falls. Go into how they feel about the safety in them walking around, because I know that my mother-in-law has had a number of different falls that have put her in the hospital. The woman is scared to walk. Okay, she shuffles her feet, not because she has Parkinson's, but because she's afraid that she may miss a step, and in doing so she's tripping and falling. All right. Changes in their assisted devices. Were they walking with a cane before they went in the hospital, and now they're walking with a walker, okay, or a rollator? Where's the diagnosis in this? Y'all, it's not that important. It is more important in medical proving reasonable and necessary. It's more important to tell me the circumstances than it is to tell me the diagnosis. Now, I'm not telling you not to tell me the diagnosis, but just a list of diagnosis does not tell me your need to be in that patient's home. Okay? It is all the ones on the left-hand side of the page that tells me your medical need to see this patient. Okay? So, providing reasonable and necessary. You need to ask yourself, and I ask myself this when I'm reading your evaluations. Why did the therapist need to be at this visit? What was the focus of this particular visit? Was this visit unique compared to the last visit? Did did you document the exercises that tie to that functional deficit? Tell me why you taught this patient these particular sets of exercises. What are they treating? They are treating the patient's quad strength in order for them to get their butt up out of the chair, okay? Or to sit in the chair without plopping. Something as simple as that. Because think about it, y'all, when Medicare reads your charts, they ain't therapists that's reading it. They're little old nurses like me, okay? They are RNs that has read chart after chart after chart. Now, y'all, I can't do therapy. I can support therapy and reinforce their home exercise program because that's in my scope of practice. But to actually look at someone, evaluate them, and determine them appropriate and create a home exercise program, that is out of my scope of practice. But I can straight up tell you on documentation whether it's going to fly or not. Okay? It doesn't take a therapist to tell me if it flies or not. Is what the reviewer sees on paper what you actually see in the home? Are you painting the picture? Okay? So, goal writing. Let's just briefly go over goal writing, because remember, it is 2 of the 3 top denial reasons that are specific for therapy. So when goal writing, you've got to have the who. You've got to have the will do what, under what conditions or when, and how well are they going to do it, and who's going to do it, or by who. All right, those are your pieces that you need to start writing when you write your goals. And avoid, oh my gosh, I went over this slide presentation with one of my therapy friends that does a lot of audits and stuff to make sure that I included all these vague terms that she reads from day to day. And I tried to make myself a list. It could be a whole lot longer than this. Y'all, do not write improved. I can't measure improved. Okay. Patient tolerated well. Well, that's great and wonderful, but that doesn't address my goals. Good progress towards goals. I see that on 99.9% of therapy notes, regardless of whether it's speech, occupational, or physical. Y'all all guilty of that. And requires less assistance. What is less? Okay. Requires 25% less assistance. Okay. Requires 50% less assistance. Okay. Give me a number. Give me something that's tangible that I can measure what less is. Okay. And let's go over goals. All right. I took this stuff straight out, the good, I took straight out of the patient's chart. And then I turned around with my therapist and wrote better goals. Okay. So this one, patient will ambulate 150 feet throughout the home with moderate independence to demonstrate improved independence with home navigation. I took it straight out of a chart verbatim, copied it, pasted it. Okay. Now, on the right-hand side, this is much better. The patient will be able to ambulate with standby assistance using a rolling walker 50 feet from the bed to the bathroom using verbal and tactile cues by 2 weeks to reduce episodes of incontinence. All right. And also, patient will be able to safely ambulate 150 feet required to get from the living room chair to the kitchen using a standard point cane with no more than 2 cues for step length and base of stance by 4 weeks. Y'all, I can see that happening. When that goal is written, I can visualize in my head what you are trying to do. Okay? Let's go over another one. Patient will exhibit understanding of total hip precautions. Y'all, every patient who has a total hip that comes out of the hospital gets that can goal, because that can goal is in every template of every electronic medical record in the United States. I have people from California doing it, and I got people from Alabama doing it. So how do we make that better? How do we make that measurable? Patient will be able to correctly verbalize 2 of 3 hip precautions by 1 week to prevent dislocation of the affected hip. And another goal that we could do is patient will be able to state the importance of keeping items close that he uses often to avoid reaching and breaking the 90-degree rule by 3 weeks. So just giving you some examples of what a good goal is that they're denying, by the way, and a better goal that would be harder to deny because you've given it meat, you've given it substance. Okay. So let's do another one. Patient will demonstrate decreased fall risk in 4 weeks. There again, templates are the devil, y'all. I'm gonna straight up tell you, templates are the devil. They make us stupid. Okay. I know they make nurses stupid, and they make some therapists a little stupid too, because they're just clicking and filling in the blank. Okay. We know that because I see this eval and I see this eval, and they got the same goals, but they don't have the same issues. So what would look better? The patient fall risk will decrease with the education and the performance of strengthening exercises in the home exercise program, as evidenced by the Tinetti score will increase from 11 out of 28 to 17 out of 28 within 3 weeks. That's a tangible. You've telling me that you're going to educate them and you're going to see them perform the appropriate exercises to strengthen themselves in that exercise program in order for them to their Tinetti score to increase. That's tangible. I can touch it, taste it, smell it, feel it. Okay? So now let's go get into the PDGM. This is, of course, a hot topic. Everything I read is PDGM, and everybody has their own little way of looking and thinking what it's going to look like. And y'all, I'm not telling you that I'm right and somebody else is wrong. We're only giving you Home Health Solutions' opinion about the way therapy needs to reinvent themselves in PDGM. So let's go over it just real briefly. So developing therapy-specific programs. We feel that programs, unique, specific programs based on your demographics, based on the area in which you serve, based on the physician referrals that you get, are going to be very useful under PDGM. Okay, because they're spelled out. They have a specific number of visits. They have specific numbers of interventions and goals that are focused directly on treating that particular issue, such as vestibular programs, hand therapy programs, y'all, wound care programs. Don't fall out. Okay, get your smelling salts out. Medication management. Let's talk about that. So the APTA believes, and this is straight out, we gave you the link to it, believes, and has been acknowledged by the federal guidance that it is within the scope of a physical therapist to perform a patient screen in which medication issues are both assessed, even if the physical therapist did not perform the specific care needed to address the medication issue. The physical therapist is competent and also qualified to serve as the case manager for this patient and facilitate coordination of care with the physician and nurses. Y'all, you can teach medicines. What this means is if I, the nurse, the RN, go out to admit a patient and I identify that this particular patient needs medication education. So say they're on, I don't know, they're on Norvasc, and they're on, which is a new medicine, but treats his blood pressure in the hospital because he had a stroke. And they're on Eliquis because the stroke was due to a clot or something. I'm making up some stuff, y'all. Okay, so those are two new medicines. Y'all, physical therapists can teach those two medicines while they are doing their therapy. So we've got to get out of the siloed approach to home care. Whereas, oh, that's in your area. No, this is in your area. No, y'all, it's in our area. So if this particular patient needs therapy, then I may take my nursing care plan, talk it over with that therapist, and have the therapist go out instead of the nurse for a period of time to teach that patient some of their medications while they're doing their home exercise program, while they're doing their interventions that are specific to treat this particular functional deficit. So you are also doing the exercises, educating on exercises, educating on compensatory strategies, and oh, by the way, you're teaching Eliquis. Okay. Wound care. Y'all, as long as it is applicable to your state practice act, okay, specifically physical therapy, okay, this is where I'm carving out a specific therapy. Y'all, there are some therapy practice acts, and I'm not going to tell you which states because I have absolutely no clue, okay, that cannot do wound care. But I'm thinking that the vast majority of the states have some carving in for therapy to perform wound care. So say for instance, I have a patient I admitted and they have a venous stasis ulcer. Well, that venous stasis ulcer is going to need to be treated. And oh, by the way, they're getting therapy for 2 weeks. Guess who's going to do their wound care while they're doing therapy? Okay. There's no need in sending me out to do wound care when you're perfectly capable of doing it while you're out there. Now, with the reverse, okay, so say for instance, they want the nurse to assess that wound 1 time a week. So maybe I'll go out 1 time a week. You're going out, the physical therapist is going out 2 times a week. You're doing the wound care on one of the visits. I'm doing the wound care and assessing the wound on the other visit. Okay, so maybe something that I would normally perform 2 times a week, I'm only doing 1 because you're helping me out. The reverse happens. Say you have a home exercise program. You're getting towards the end of your frequency. I'm going out also for something that is unique for nursing. So what I can do as the nurse is you and I are going to talk. The therapist and the nurse are going to talk. You're going to tell me what it is that you're treating, and I'm going to reinforce that when I'm in the home. I'm going to take that written home exercise program and I'm going to look at it and say, hey, I want you to go over a few of these exercises with me. Let me make sure that you're doing it appropriately and that you're doing it safely. Y'all, that's within my scope of practice to perform. So that's what I mean by thinking outside of the box. We have got to be out of these siloed, that's your area, this is mine. Y'all, this is the patient, and we're all around this patient treating them. Okay? Not just focusing in with blinders. Okay? So, PDGM, so underutilization, of course, can lead to very poor outcomes. Of course, overutilization, you ain't going to make no money and you're going to end up shutting your doors. So there is a balance in there, y'all. What that balance is, I don't know. Okay, I'm going to straight up tell you, I don't know. Some people say front end load. Some people say, well, da 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 da. I've heard all kinds of different things, and that doesn't mean that no one thing is correct. That just means that we all have our opinion based on the statistical data that we've plugged into the to the grouper. I'll spit it out in a minute. Oversight of all the services and resources, maintaining contact. Y'all, we've got to communicate with each other, because if I don't know what you're doing and you don't know what I'm doing, then the patient's not going to get good outcomes. Okay, and we're not going to take Medicare's money and use it appropriately. So PDGM, clinical pathways. Remember, I told you at the beginning that doing specific programs would be beneficial, because those things are written cut and dry. Okay, they're written where you perform certain tests, they suggest certain frequencies, they suggest specific disciplines and what their position is in this particular plan of care, the appropriate education, okay, self-management, long-range needs and planning. So we may want to incorporate a social worker into there, social determinants, management tools, tracking logs, making them accountable, the patient accountable, using current practices, processes of developing pathways, and multidisciplinary planning committees. So we're all getting at the table instead of saying, well, I'm doing this and you're doing that, and they're improving, they're making progress. That's not going to fly in your case conferences. You've got to have some substance to them. And of course, PDGM, it is not just nurses. The APTA pressed for clarity from CMS that physical therapists will be included among the providers able to conduct remote monitoring. Now, y'all, remote monitoring is a way for you to not go to that patient's house, but be able to see that patient perform their exercises and provide them verbal cues. Okay, so in the final rules, CMS clarified that it is indeed the case that as therapy goals must be established by the qualified therapist in conjunction with the physician while determining the plan of care. We believe, Medicare believes, CMS believes therapists involved in the care planning, as well as other skilled professionals active within their scope of practice, may utilize remote patient monitoring to augment their process. So, for instance, you may want to see the patient 2 times a week, or 3 times a week, but maybe you want to take that third visit and Skype with them, or do some type of, there's a lot of, now this is not for every patient, of course. We got a lot of patients that are not tech savvy, but y'all, as the baby boomers are moving in, these people are tech savvy. They can use their cell phone. They know how to use it. They can text. I mean, y'all, my mama's 80-something years old, and this woman is a texting fool. Okay, so as these people get into the 65 and older bracket, as these people are getting their knees replaced and their hips replaced, we can use that tool in order to augment or supplement some of our visits. Okay, because the more visits we make, the less money we make, and that's just the bottom line. So we've got to have a balance, but still have good patient outcomes. So PDGM and medication management, we've already talked about, maybe the therapist needs to teach a few of those medications and then the nurse needs to go in, okay, or supplement it. Wound care, we've already talked about that. Disease education. Y'all, therapists can teach about COPD just like I can. Assessment of their weight and blood glucose. Okay, when you're in there as a physical therapist, this patient has congestive heart failure, ask them about their weight. Okay, we're trying to keep them out of the hospital, ask them what their last blood sugar was. Share the home exercise program and goals with the nurse. so that we can assist you in patient participation, so that when we walk in the home, we are doing what we're doing there, but we're also encouraging the patient to follow your home exercise program, and we'll report back to you how they did. Oh man, you gave them those new exercises to do on paper. We went over them and they are rocking it. Okay, they've exceeded their goals. They're really doing well. Or, hey, look, this joker is not going to remember all these exercises. Or every time I watched him do it, he did it unsafely. So maybe we need to modify that. So that's the conversation that we need to have with each other. So we have come to the end. I know that people have questions. I'm hoping that somebody put on the site, I'm hoping that people put on the site the handouts. If not, then we will try to get those handouts to you or make them available to you. I'm sorry about that. I will try to remember. That is 100% my fault. So, you probably got questions, but there again, reminder that, go to our online shop. We've got a few tools that we're going to start coming out with that are specific for therapy, that is going to help you in this PDGM world. So let me go to the next slide. So just letting you know, I'm not a salesman. Okay, I'm gonna straight up tell you, I'm 100% clinical. So just to let you know that. Now, you do have my email address. I think it's attached to this. It's Heather at Home Health Solutions with a S, LLC.com. So if there's any questions that people may have, I've got a few that are on here, and I think most of them are, where are the slides? Could you email me the slides? Will the webinar be available via recording? Yes, it will. If you attended today, if I'm not mistaken, if you attended today, then you will get a free copy of this presentation. Okay, the audio presentation. If you were not able to attend, I think that they're going to make you buy it on site, on the solutions for a nominal fee, because this is a pain in the butt to send this stuff out. But if you took the time to actually, if you took the time to sit through this webinar in my Southern accent, then we're going to give you a copy of it. Now, I did have somebody tell me that they disagree entirely with do not use the tug. Y'all, I'm just telling you what Medicare says. Okay, what Medicare has suggested, that a tug is just not enough. All right, you need to use a more complex tool to measure your improvement, to measure your patient's functional deficits in order to improve on those. I'm just I've seen the trending. I've read too many charts, okay, that they have the tug, but yet they're still denying it because they didn't use any standardized tool. It has taken until 3 appeals in order to get it overturned. So if you've got other tools to use, now y'all, I know the tug takes no time to do, and that's a lot of reason why therapists use it, because it doesn't take a whole lot of time. Y'all, you have got to start using something that is a little bit more comprehensive, okay? Something that is within your specific therapy toolbox, not the one that I can use. You need to use one that's appropriate for the patient, not just the tug. That's more of a fall assessment. Let's see. Will there be options for watching it again? Yes, there will be. Sir, will we obtain certificate? Y'all, I don't give CEUs for this kind of stuff, because it specifically through your therapy boards. Oh my gosh, some of these therapy boards, Alabama, for instance, it's an act of Congress to get anything approved for PT, and well, not necessarily for OT. OT and ST I've been pretty good at, but PT, man, they're locked down tight here in Alabama. So I can't fathom what they would be in other states, specifically like Texas and stuff. Ugh, I ain't doing it, y'all. So, that's really the bulk. If y'all, like I said, again, if you've got any kinds of different questions, you need to just give me an email, agree or disagree. I want some feedback, y'all. So it's Heather at Home Health Solutions with a S, LLC.com. Okay, so thank you so much, and I look forward to seeing everybody or talking to everybody here in 2 weeks. Everybody have a really good Thanksgiving and enjoy a little bit of time off. I hope y'all do have some time off because you really do deserve it. So thanks again.